First, let's assume that this is one of your staff members. That would be nice, wouldn't it? That would be nice. And you ask her, is NAFA the right thing to do? And then she could answer, of course, to you, what, NAFA, what's that? And I think that's reasonable. If she said, NAFA, what's that? And she didn't hear yet about NAFA, it's okay. But she could also say, NAFA, yes, I know, so what? That could be another answer. And maybe she's right either. That could be a real good answer anyway. But the last thing is, yes, I know what NAFA is. I know that it works, but I'm not going to use it in my particular patient. And that, I guess, is what's happening quite often in our ICUs. And we call it the quality gasm. And you know that very much. We do have many, many, many effective therapies in the ICU, but they do not diffuse into patient care. That's what actually happens. Year after year after year, people keep using their old habits and not using effective new therapies. So that could be the case with NAFA also. And for that, of course, we need something that is called implementation science. Now, I'm going to talk a little bit about general issues in implementation science, and Leo will talk about how NAFA was implemented in our ward. Now, there are some very important issues, and I would say 6 in the literature, that are associated with a very slow implementation. And the red marks may apply to NAFA also. First of all, it's a complex measure without a rapid evidence of improvement. That could be the case. We don't know yet, but all the complex measures, and NAFA is complex compared to pressure support, let's say, without a rapid evidence of improvement, that could lead to slow implementation. Essential information is not immediately available at the time of decision making. That's another boundary, I would say. And then the last one, also very important, it contradicts clinicians' experience. We as a clinician are used to, we have one knob in the machine and you turn it to the right and something goes up. Tidal volume or pressure, something like that. And in this case with NAFA, that's usually not the case. So maybe we should change that a little bit. But that's an important thing for a doctor, I would say. And the other 3 important things from the literature are measures that prolong patient encounter. I don't know what happens if you start weaning a patient with NAFA. We all expect it to be shorter, but we don't know how to dial down the NAFA level. We have no experience with that yet. And it could even lead to longer weaning. That is still a possibility. Inconvenience to the patient, probably not the case as we heard today with NAFA. And then, of course, the insignificant effect on outcome. And the real thing is, we discussed it already a little bit, we don't know yet. So, as you can see, these are 6 very important boundaries in the literature. And I think a few of them could apply to NAFA also. So how can you improve implementation? Now, there are some general theories, of course, but much of the usual measures are not very effective. Of course, we often use so-called reminder techniques. Let's say a pop-up on your computer screen that says you have to do this or that or something like that, or it's time to do this, etc., etc. And it usually improves the implementation process around 15%. These are means from the literature. I'll show you some examples in a few minutes. Of course, you should give everybody educational materials. That's what we did in our NAFA introduction. But it only changes implementation for a small part. Audit and feedback, we often do that. A lot of evidence for that, but only 7% increase. And then, of course, educational outreach, only 6% increase. Now, a very nice example was this one from the group of Marcus Schulz from Amsterdam. They had just one change. Their implementation strategy was one simple change for getting a lower tidal volume into most of their patients. And they had just one simple reminder for the lower tidal volume strategy. That was in their computerized system. They had a pop-up every day that the doctor entered the system, he got this message: according to the ICU guideline, our ICU guideline and international literature, the volume is so-and-so, 6 ml per kilogram. This is your patient. The ideal volume is this. Check whether you are following the guideline, yes or no. And when they did that, only in patients ventilated longer than 24 hours, they saw that the average tidal volume above 6 ml per kilogram decreased with 80%. Like I said, 50% success with a single reminder. And the time with the tidal volume above 6 ml per kilogram decreased with approximately 10%. Now, I'd like to tell you a little bit about our implementation strategy, and Leo is going to tell you about the NAFA. But we had an implementation strategy of a delirium screening tool a few years ago. That was published in Critical Care. And we wanted to implement, it gives you more or less an idea how these things actually work in clinical practice. We wanted to implement the CAM-ICU in December 2007. And we started, and I think that was a very important start. We started with unstructured interviews with our nursing staff and our medical staff to identify potential barriers and facilitators for the CAM-ICU. And the nurses and doctors, they came up with some barriers. Of course, lack of knowledge with us and with the staff and with the nursing staff. The unavailability of the assessment tool. A lot of paperwork. They had to do that 3 times a day at least. They thought that the time to perform the assessment was very important, but they also came up with some facilitators. Of course, the patient management system, we had to computerize it. They wanted to have senior nurses that coordinated everything. They wanted, of course, support of the medical and the nursing staff, of the opinion leaders, of course, that was important. And they wanted a delirium researcher who would be there in the unit every day and answering all their questions. That's what they wanted. So we finally organized that. We did a lot of education. We did all 4 things, not just one, all 4 things. We had a lot of educational outreach. We had a lot of computerized reminders. With every shift, the nurses, they came to the computer screen and then it said, did you fill in the CAM-ICU, yes or no? So that was an important reminder, and of course, we showed strong leadership for this. Now, this is how it looked like. Here you can see it's very complicated, such a scheme, but that's what happens when you want to introduce something successfully in your ICUs. This is prior to the implementation. We started with the potential barriers and facilitators. We built a computerized CAM-ICU algorithm. Then we started with a knowledge test with the nurses and the doctors. We started the implementation. A lot of it was actually education. Here you see it. We did inter-rater reliability measurements. We repeated that often during the implementation process. We had a lot of compliance measurements and feedback. We trained them on the job for 2 months. And then finally, we ended the implementation in March 2008 with a second knowledge test. And these were the results. Inter-rater reliability increased from the first month to the last month. The compliance increased from 70% to 92.5%. And the scoring rate for the nurses and for the doctors, the knowledge about delirium, also increased significantly. Did it stay that way? Yes, because it always has to stay there for a long time. This is 2 years later, so this is 2010, and you can still see that the screening rate for delirium in our ward is still, with all the months, 95%. So this was, I would say, a proper implementation. And I dare to say that if you want to implement NAFA in your own unit, you need something like this also. Otherwise, you could end up with a mess. Some people getting it, some not. And that's not very nice. So what's also very likely very effective in implementation, of course, like we always said, opinion leaders, like here, affecting the culture change. Of course, an organized approach, upfront training. And I think this is the most important, and that's what Leo did with the NAFA introduction in our unit, ongoing troubleshooting of problems. You have to be there all the time for the nurses and for your colleagues to answer all the questions and get rid of the troubles. So that's what we did in NAFA implementation. Well, what could also be useful, alternative method. Financial incentives, they're going to be very important in the future. All our insurance companies are already using them, so that definitely will be an incentive in the future. Of course, public reporting of outcomes, also something that's slowly starting to get into medicine, also I think very important. And then of course what I like very much, the peer institution programs, combining implementation of best practices with a research agenda. And that brings me to the last slide. I would say what is absolutely necessary for NAFA right now. I hate it if it would be the same as we had with proportional pressure support or proportional assist ventilation 5 or 10 years ago. I was at that time totally convinced that that was also an improvement compared to pressure support ventilation, but it didn't make it to the clinics. It was not properly introduced, I would say, not only in the Netherlands, but almost never in Europe. And it ended up with, I would say, not a disaster, but didn't work out very well. So we definitely need convincing evidence now that NAFA improves patient outcome. Of course, that's important, and we have to work on that together. I think we need a simplified NAFA dosing tool. It's, once again, for a doctor, if you turn the knob to the right, you want the volume or the pressure to go up. And that's not what's happening right now. So maybe you should call this knob something different. And there are already some ideas I just heard. Of course, you need strong opinion leader support. Now, a few of the really opinion leaders in the world are actually here and showing their support, so that's very important. And we need definitely, for different situations, tailored educational programs. I thank you very much for your time.